afternoon. I think it's time to begin our briefing for today. Thank you for all of you who are calling in. My name is Kim Stanger. I am the co-chair of the firm's Health Law Group, and this is our second Monday briefing concerning the coronavirus issues and legal issues that come up over the past week or so. I'd like to introduce my colleagues Brad Cave and Jay DeVoy, who will also be discussing different legal issues with us today. To begin with, we'll turn the time over to Jay, and he's going to discuss some of the issues concerning telehealth and other developments. And then I'll talk a little bit about the CARES Act, and then we'll turn the remainder of the time to Brad to talk about the CARES Act and how it impacts some of the other labor and employment issues and the additional guidance we've got on labor and employment issues. So with that said, Jay, do you mind taking it away?
No, my pleasure. Kim, thanks for turning it over. There's two main issues that I want to talk about today, namely about telehealth and also the directive that came out very late last week and was covered this weekend regarding the Department of Health and Human Services Office for Civil Rights. Turning first to telehealth, there's been some activity on this, and you addressed the majority of it last week with respect to discussing the changes that had been implemented by the DEA and other changes that have been implemented by CMS for payment and other requirements for participating in telehealth, which normally has relatively restricted and narrow reimbursement allowances within Medicare. And that's been expanded, most importantly with Medicare, to allow for greater flexibility for reimbursement for professionals who want to provide those services and have reimbursement through Medicare and the various payment models there. And then for the DEA, the most significant change was allowing practitioners to establish a relationship for the first time through telehealth in order to prescribe. Now, normally, what would happen is the relationship could only be formed in person and maintained down the line through telehealth for the purpose of prescribing under DEA regulations, but the DEA has issued guidance that that is no longer going to be the case for this period of time, and eventually that will change as time goes on. Presumably once this COVID-19 situation abates. So with respect to the DEA, there's been no further guidance in that area, but for CMS, there has been some additional guidance with respect to payment issues, mostly on the payer side. On March 24th, 2020, there was additional guidance issued by CMS on the topics of availability and usage of telehealth services through private health insurance coverage in response to COVID-19. And this addressed only a handful of issues. There are three main questions that were addressed in this guidance that was issued by CMS, and it had to do with issuers of individual and group market plans to amend their benefits during the plan year to provide for and expand coverage of telehealth services, and also to allow for the use of these services and having them being covered by insurance before the deductible amount had been reached for that plan. So it's mostly payer-focused. It has to do with what individuals can do within the scope of their plans, the changes that plans can make in the middle of the coverage year, generally to increase the availability of telehealth coverage both for individuals and for practitioners in terms of being able to use those services and being reimbursed for it. The animating purpose behind these changes has been to further isolate both individuals and practitioners to avoid the spread of COVID-19. So there might be more guidance forthcoming in that area, but this is just the guidance from CMS for private payers to make sure that their plans can change throughout the year to accommodate these issues. One topic that has come up frequently, though, that relates to the DEA, even though we're awaiting further guidance in that area, is that certain state licensing boards have been quicker to follow it than others. Speaking from my experience in Nevada, there is a whole regime of state laws that have been implemented and augmented starting in 2017 that address the prescribing of opioids and other controlled substances. And my impression is that the state licensing boards here, including the Board of Pharmacy and the various medical boards, have been slow to respond and adapt to that. So as a general rule, although we have this great federal regulation that has changed in some other guidance and waivers that have been issued by the federal government, they haven't necessarily been adopted and certainly have not, in my observation, been adopted consistently among the states. So it's important for everyone to check with their state licensing agencies. For some of these regulations and changes, the states have been fairly aggressive in seeking Section 1135 waivers, which I believe we'll be addressing at some point in this call, and were addressed in some length at the prior call, and have been implementing those changes as they're implemented by the federal government. But for some of these changes in terms of harmonizing state regulations with the federal regulations by either adopting emergency regulations or emergency orders and executive orders that basically allow the federal regulations to supersede state regulation, that has been a patchwork, and in my observation about it, has not really happened yet. So it's important to be cognizant of that to avoid second-order effects where complying with federal law and regulation and this enhanced federal guidance that has come out doesn't lead to potential state issues down the line, and taking proactive steps where if there is going to be compliance with the federal guidance and it's inconsistent with the state, seeking guidance from the state on that issue, and if the state won't provide guidance, making sure that compliance with federal law is documented as a reason for taking the course of action that was taken. Secondly, the Department of Health and Human Services Office for Civil Rights issued its guidance that I mentioned earlier regarding Section 1557 of the Affordable Care Act. That was adopted with the passage of the Affordable Care Act, and it has to do with basically integrating Title IX and some other areas of federal law into the delivery of health care, so there's no basis for discrimination along protected classes. There's been some litigation that's been spawned, and parts of Section 1557's implementation has been stayed by various courts as certain areas such as gender identity and the obligation to provide coverage for certain procedures that affect pre-birth and termination of pregnancy activities. So that has been kind of a controversial section in the past, and it's been subject to litigation, but to the extent it remains in effect, and is in some cases narrower than state laws for certain states like Michigan that recognize protected classes beyond those of age, disability, gender, and race. I know that some of these states have expanded their definition of protected classes to include, for example, body weight. And the federal regulation has been, or rather, the guidance from the Office for Civil Rights has reemphasized the fact that it will continue to enforce civil rights obligations throughout the COVID-19 pandemic. And the tacit warning to states was that they cannot ration and they cannot apportion health care based on any kind of immutable trait that's controlled by these civil rights laws. In particular, this has to do with age and disability, and that was specifically referenced in the statements that the Office for Civil Rights made to the media regarding this. And this is in response to the activity that some of you may have seen on social media and people have been discussing, where there's some discussion going on within healthcare providers about the reality of potentially having to ration and apportion healthcare. And the Office for Civil Rights likely isn't blind to the fact that there may be shortages in the future, and the reason for the federal and state responses have been on trying to mitigate those shortages. But the issue here is that the Office for Civil Rights is very concerned about those kind of shortages and the apportionment of health care being done not based on any kind of first come, first serve policy or outcomes and likelihood of successful treatment, but on basis of age, in particular, other health conditions and disability as defined by the Americans with Disabilities Act. So that is something that's likely going to factor into the policies and procedures that are implemented as time goes on by health systems and by hospitals to deal with the apportionment of care as resources become more strained and more limited, and coming up with ways that are neutral at least to these kind of factors, and a deeper dive will be necessary as this goes on. And if there are shortages, to avoid any kind of follow-on claims where just having a plan of apportioning and rationing these resources isn't necessarily blind to these kind of these protected classes such as disability and age and gender and race, but also avoids things such as disparate impact, where even though you have facially neutral criteria, different groups are disproportionately affected. And that is the challenge that I see coming ahead in the following weeks and months as this crisis deepens and as this policy is enforced by the Office for Civil Rights, and hopefully we'll have more guidance as to what they're looking for as this goes forward. And that's all I have for that right now, Kim, unless you have any specific questions that you'd like to get into before we continue on with the presentation.
No, that's great. Thank you very much. That brings us to the CARES Act, which is the huge issue that came out last week. In fact, it's so huge, it's $2 trillion worth of stimulus package. That was passed on Friday. we distributed a client alert on last Friday. If you didn't receive that and would like a copy of that client alert that summarizes the major portions of the CARES Act, by all means email any of us and we can make sure that we get that to you. But Brad and I wanted to highlight some of the more relevant portions of that CARES Act. We're still sifting through it, and we don't have a lot of details yet. The CARES Act generally put in place the structure, but we've got to wait for additional guidance concerning how portions of it are going to actually implement it. The most important parts, or the parts that are probably of most interest to all of you on the call, are those relating to funding. I'll talk about the general issues that are specific to healthcare. Brad can pick up other issues when he takes the mic. The one that's probably most interested to you is that under the CARES Act, they established an emergency fund that through which healthcare providers are slated to receive approximately $100 billion for COVID-19 related expenses and lost revenue. Eligible providers are defined as public entities, Medicare or Medicaid enrolled suppliers and providers, and other for-profit and nonprofit entities as specified by HHS. We don't have the guidance yet from HHS. We anticipate that will be coming relatively soon based on some of the other action that they've taken. But we'll have to wait for the details on that. We are told that the funding will be on a rolling basis through the most efficient payment systems practicable to provide emergency payment, whatever that means. So that's the big ticket item for you healthcare providers. For those of you who are hospitals, there are additional funding mechanisms that have been put in place. For example, hospitals and critical access hospitals, children's hospitals, and certain other hospitals may participate in the accelerated Medicare payment program during the COVID-19 epidemic. Now, that was available to hospitals before, but the CARES Act expands that and makes it available to critical access hospitals and other facilities. Yesterday, the CMS issued FAQs explaining how that accelerated Medicare payment program is going to work. I sent out an email this morning to a lot of you. If others of you would like to receive that, by all means, let me know. Shoot me an email and I'll get it to you. But it's available on the CMS emergency website. Basically, those FAQs confirm that this payment program, this accelerated payment program, is available to any Medicare Part A provider and Part B suppliers. If they apply, they have to go through an application process, and the FAQs contain a link that walks you through the process. And they have to qualify. In order to qualify, they have to have billed Medicare for claims within 180 days prior to the request. They can't be in bankruptcy. They cannot be under active medical review or program integrity investigation, and they don't have outstanding delinquent Medicare payments, overpayments. Now, the amount of the payment that the hospital or other provider or supplier can receive, it depends on the type of provider. For most providers and suppliers, they may request up to 100% of the Medicare payment for a 3-month period. For inpatient acute care hospitals, children's hospitals, and certain cancer centers, they're able to request up to 100% of the Medicare payment for a 6-month period. And critical access hospitals can request up to 125% of the Medicare payment for a 6-month period. When it comes to the repayments, those repayments have to begin 120 days after the issuance of the initial payment. The hospitals and critical access hospitals then have up to 1 year to repay the balance. Other Part A providers and Part B suppliers will have 210 days from the date the accelerated or advanced payment was made to repay the balance. The MACs are committed or assigned or supposed to work to review and issue those payments within 7 days. So for those of you who are Medicare Part A providers or Part B suppliers who are eligible to participate in the program, this is something I'm assuming that you will want to get right on and see if you can help to get those payments in to help manage your cash flow. In addition, there are certain other benefits or funding sources for hospitals. Among other things, the CARES Act increased the inpatient prospective payment system weighting factors for DRGs associated with COVID-19 patients by 20%. So you can get an increased reimbursement for COVID-19 diagnoses. In addition, the CMS has delayed reductions to the disproportionate share hospitals, those DSH payments. That will be now postponed through the end of the year. There's an additional $250 million that will be made available to entities that are part of the hospital preparedness program. There's $1.32 billion available for community health centers. There's an additional $150 billion that the government has appropriated to send to states, local governments, and tribes for COVID-19 related expenses. Of that, each of the states is guaranteed to receive at least $1.25 billion. Additional amounts are allocated based on the state's population. There are additional provisions in there for funding for different types of issues, including increases for certain Medicaid FMAP portions for certain types of states if certain criteria are met. There's additional Medicare issues for certain types of providers, including post-acute care providers. As Jay may have mentioned, that there is the expanded payments for telehealth services for certain types of providers, including FQHCs and RHCs, dialysis providers, hospice providers, and home health that will allow you to provide services, obtain certifications, and the like that are necessary to obtain Medicare payment, and you can do that through telehealth. There is other relief available to all businesses, not just healthcare providers, including the SBA loans that I think Brad will cover briefly. In addition to those SBA loans, Title IV of the CARES Act has a catch-all that is reserving, I think, $500 billion in order to help offset expenses for large businesses or mid-sized businesses. Large businesses are over 10,000 employees. Mid-sized businesses are 500 to 10,000. Those are generally available to businesses that do not otherwise qualify for the SBA loans or other programs under Title IV. Those are addressed in more detail in our client alert that we send out on Friday. Those are the primary funding issues that are in CARES Act. In addition, there's some additional specific provisions for healthcare providers, including coverage for COVID-19 and other services. Specifically, they've expanded coverage for the COVID-19 diagnostic tests. During the current emergency, providers of COVID-19 diagnostic tests are required to publish their cash price for those tests on the provider's public website. If they fail to do it, they can get hit up with a $300 fine per day that's not done. And then they use those cash prices in order to determine payments for systems, because the CARES Act builds on the Family First Act that required coverage for COVID-19 through different private and public payment programs, and you have to make those coverage for those diagnostic tests without copays. Under the CARES Act, it extended those requirements that were in the Family First Act, so it not only applies to FDA-approved tests, as it was in the Family First Act, but also it extends to other types of tests, including tests that are provided by labs on an emergency basis or that are approved by state government. Group health plans or health insurers that cover COVID-19 tests are obligated to reimburse the provider for the diagnostic test. The amount that they have to reimburse depends on whether or not they have a negotiated rate or not. If they had a rate in place before the public health emergency was declared, the negotiated rate applies through the period of the declaration. If there was no negotiated rate in place, the plan or insurer shall reimburse the provider an amount that equals either the cash price for such service as listed on the provider's public internet website, or the plan or insurer may negotiate a rate that is less than the cash price. There is some concerns that the way that it's written would allow out-of-network labs to basically increase the cost, because the private plans and the other plans would have to pay their cash price, and so it might create for the inflation of those diagnostic tests, but we'll have to see how that's addressed. In addition, the CARE Act expands the availability of COVID-19 vaccination and preventative services without cost sharing once those vaccinations are developed, and we all hope that is soon. Among other things, group health plans and health insurers must cover qualifying COVID-19 preventative services as specified in the regulations. They can't have any cost sharing. The effective date of those requirements depends on when the services are recommended. There are certain other provisions in the CARES Act that are specific to healthcare providers, including there's a provision that allows for immunity for healthcare professionals who are providing COVID-19 services if they are a volunteer, meaning that they're not receiving compensation for providing those services. They act within the scope of their licensure in the good faith belief that the patient needs the services, and they do not act with willful or criminal misconduct, recklessness, or gross negligence. In addition, the CARES Act expands certain home-based services, including allowing face-to-face visits for home dialysis patients through telehealth rather than an in-person face-to-face visit. It also expanded certain home care services, like home health agency services, by allowing nurse practitioners, clinical nurse specialists, and PAs to certify those health plans so that they don't have to necessarily be certified by physicians. There are a couple of provisions in the CARES Act that affect privacy. For example, they modified 42 CFR Part 2, which is applicable to substance use disorder treatment programs, to more closely align with HIPAA. Essentially, it allows the SUD program in order to get the patient's consent and then use the information for purposes of treatment, payment, and health care operations. There's additional provisions concerning breach notification and the like. In addition, the CARES Act instructed HHS to issue regulations governing the disclosure of information relevant to COVID-19. We'll have to watch for those regulations to come out. There are also general provisions in the CARES Act that are meant to expedite the availability of drugs to fight COVID-19. There are measures to, in the future, avoid supply chain disruption or equipment or supply shortages. And there's other changes that will affect things like tax benefits, HSAs, use of employee benefits in order to help pay for these expenses. With that said, I'll turn the time over to Brad, and he can talk about additional issues that come up in the CARES Act, as well as how it might affect the Families First Act and other labor and employment issues. Brad?
Thanks, Kim. I'm going to begin with the Family First Coronavirus Response Act questions and answers that the Department of Labor put out on Friday, because they had substantial positive benefit for healthcare employers. If you recall, last week we were all operating under the definition of healthcare provider that's found under the Family and Medical Leave Act. And that definition, when coupled with the Families First Coronavirus Response Act, had defined a very limited scope of professionals that could be excluded from the leave provisions under the Family and Medical Leave Expansion Act and the Paid Sick Leave Act. So narrow was that list of excluded positions that many of our clients were very concerned about their ability to continue to operate with all of their nurses and their CNAs being eligible to take the leave for up to 12 weeks. On Friday, the Department of Labor issued amended Q&As that greatly expanded the definition of healthcare provider. I'm going to read you a pertinent portion of the definition of healthcare provider. It's now defined as anyone employed at any doctor's office, hospital, healthcare center, clinic, nursing facility, retirement facility, nursing home, home healthcare provider, any facility that performs laboratory or medical testing, pharmacy, or any other similar institution, employer, or entity. And that's anyone employed. So regardless of the position or the title or the job, anyone employed at any one of those facilities is now considered a healthcare provider for the purposes of exclusion from the Family First, the leave programs under the Family First Act. The Q&As also provided us with the definition of emergency responder, and that person, or emergency responder, is now defined as an employee who is necessary for the provision of transport, care, health care, comfort, and nutrition of such patients. I believe that means COVID-19 patients, or whose services are otherwise needed to limit the spread of COVID-19. And then they go through some expansion or some further explanation of that to specify that it includes but is not limited to emergency medical services personnel, physicians, nurses, public health personnel, EMTs, paramedics, persons with skills or training in operating specialized equipment or other skills needed to provide aid in a declared emergency, as well as individuals who work for such facilities employing these individuals and whose work is necessary to maintain the operation of the facility. So to the extent the expanded definition of healthcare provider didn't catch everyone, I think the expanded definition of emergency responder now does so. So where does that leave us as healthcare providers and employers in this field? It now looks like the majority of healthcare providers will be able to elect to exclude their entire workforce. I think that simply raises the question of whether you should exclude your entire workforce. The definition, or I'm sorry, the consideration of that question will be different for all of you. Obviously, even in a hospital setting, you will have some members of your staff who are not directly involved in treating your patient load because their units have been maybe have been shut down. If elective surgery units, for instance, may not be doing elective surgeries or situations like that. So whether to exclude the entire workforce is a question that you will need to answer on an employer-by-employer basis. The DOL did include an encouragement for employers to be judicious when excluding employees from the leave rights because of the overarching need to minimize the spread of the virus. I'm highly confident that all of you on the call have more clinical expertise available to you on that question than the DOL does. So you'll be making those decisions based on your clinical expertise. We still don't have any guidance on how you elect to exclude categories of employees. It is still our advice and our suggestion that you notify employees individually as much as you possibly can. And if you can't individually notify employees, we believe you can send a general communication that identifies categories of employees who are excluded, and that should satisfy what the Act requires. You will need to communicate with those employees, however, in order to avoid misunderstandings. I do not suggest that you wait until employees start asking for leave before you tell them they're excluded. That will simply raise a variety of other problems that you'll have to deal with as an employer. Interesting questions about the notice. If you decide, well, let me back up one step. The Paid Sick Leave Act required the posting of a notice, and that notice came out last week. And I think I and my colleagues emailed it to many of you. But if you need the notice, it's available, and I can send that to you. The notice is required for all employers who are subject to the Act. So even if you're a healthcare employer and you can exclude your entire workforce based on the definition of healthcare provider, you are still required by the Act to post the notice. That makes no sense. I understand that. It didn't make any sense when, under the Family and Medical Leave Act, all covered employers were required to post the notice, even though they may not have had any eligible employees. Same is true under this Act. So you will need to post that notice. You can do so by email, you can do so by direct mail, or you can do so on an employee intranet web page, or you can do it the old-fashioned way by putting it on bulletin boards. Now, if you're excluding employees, it makes it doubly important that you communicate with those employees and let them know that, hey, this notice, although you see it around, it doesn't apply to you. We've excluded your position for the purpose of treating our patients, and whatever other message you want to communicate along with this. But because the notice has to be posted you will need to communicate about exclusions prior to or in conjunction with sending that notice around. Also keep in mind if you're a public agency employer or if you have 50 or more employees and you're a private entity, you are still covered by the traditional Family and Medical Leave Act, regardless of the Families First Act. So if any of your employees become ill or if their family members become ill, they will have traditional Family and Medical Leave Act rights to leave. So don't allow this exclusion issue to distract you from the fact that there are still traditional Family Medical Leave Act rights when there's an actual illness of a family member or of an employee. So since our last webinar, the Q&A answers from the DOL have continued to come on a variety of topics. I encourage you to review those. There is some good information there. A word of caution, however, the DOL has changed some of the answers to their questions after the original answer has been posted, and they haven't really told you which ones they've changed. So you need to kind of keep up on those. For example, on Thursday, they posted an answer to what kind of documentation does the employer need to get from an employee to support a request for leave, and what kind of documentation does the employee need to provide. By Saturday, that answer had been pared down significantly and was not nearly as demanding as the original answer was. Now, the DOL didn't come out and tell us that's what they had done. They didn't indicate that revision had been made, and one of my colleagues caught it because she had been studying the prior version. So the DOL is using this Q&A process. The statute actually says that they shall issue regulations. This Q&A are not regulations in the legal sense of the word. So we are relying on these Q&As. I think we can safely rely on these, but we need to be aware that the DOL, because these aren't regulations, they can change these as they see fit. So let me just cover a few of the Q&As. I'm gonna cover them pretty lightly just for the sake of time. One of the main areas of questions by employers has been on sequencing of the leave, particularly when the leave is because the child's home from school. Under that circumstance, the Q&A has made it really clear that the employee is entitled to use the Paid Sick Leave Act leave for the first 2 weeks, followed by the FMLA expansion leave for the following 10 weeks that the child is home from school. They can substitute for 2 weeks, or they can substitute employer leave for the first 2 weeks, and then you can agree, employers and employees can agree after that first 2 weeks to allow employees to use a portion of to use employer-provided leave to cover the remaining 1/3 of their pay. So first 2 weeks, the employee has the option to use the leave. Well, for the remaining 10 weeks, the employer and the employee can agree to allow the employee to use accrued leave under employer policies to supplement the pay. The Q&A gave some good telework advice. Teleworking is all a matter of agreement between the employer and the employee. There is no mandate that every employer permit telework. It's purely a matter of agreement. The schedule of the telework is a matter of the agreement. The employer and the employee can agree that the employee will work for X number of hours during this period of the day. They can change the normal schedule or agree to hours outside the normal schedule. And the Q&A make it clear that the Paid Sick Leave Act leave can be taken intermittently with teleworking if the employer and the employee agree on it and agree on the schedule. Intermittent there's good explanation of intermittent leave and when it's available. It's only available, intermittent use of the Family and Medical Expansion Leave and the Paid Sick Leave Act leave is only available when you're working from home or when you're working away from the workplace. Intermittent leave is only available for the qualifying reason of the kid who's home from school due to school closure. And when I say intermittent leave, I mean you're taking part of your workday, part of your normal schedule, you're staying at home to take care of the kid, and you're coming to work for part of the schedule. The Q&A make it very clear that that kind of intermittent leave between home and the workplace is not available for any of the other qualifying reasons under the Paid Sick Leave Act. All of those other qualifying reasons are related to potential illness. And one of the purposes of the Families First Act is to provide paid leave so individuals will not come to work and potentially spread the virus. So the only time you can use home and worksite intermittent leave is when you're staying at home for part of your work schedule to take care of your kid who's home due to school closure. The Q&A gave us good information about closures and furloughs. The basic rule is that if an employee is sent home due to reduced scheduling, office closure, or because the employer does not have sufficient work for the employee, either before April 1st or after April 1st, the employee is not entitled to paid sick leave or FMLA expansion leave because the time off is not for one of those 6 reasons under those 2 laws. So even if they're already on leave under the FMLA Expansion Act or the Paid Sick Leave Act, that leave ends when the employer either closes the workplace or would have sent the employee home without work due to business conditions. So it's pretty general rule there. I advise you to consult with your counsel on the particulars of that when it comes up in your situation. The Q&A made it very clear that under the FMLA Expansion Act, those weeks that are used under that act are limited by any prior FMLA use by the employee. Every employer who's covered by the FMLA has a 12-month period in which their eligible employees can use up to 12 weeks of FMLA leave. The FMLA expansion leave counts against that 12 weeks and is limited by that 12 weeks. So an employee who used 10 weeks for a serious health condition earlier in the year is now limited to 2 weeks to stay at home and take care of the kid whose school is closed. The guidance or the Q&A talked a little bit about the tax credit reporting. The tax credits are limited to the pay that's available under the Act, not to any additional accrued leave or pay that the employer allows an employee to use or that the employee can use. We're all waiting for the documentation requirements, so our files will be complete if we take the tax credit. What the Q&A said last week was, if you intend to claim a tax credit under the Family First Act, you should retain appropriate documentation in your records. You should consult the IRS for applicable forms, instructions, and information and procedures that must be followed to claim a tax credit, et cetera, et cetera. Well, the IRS has said nothing about that yet. They put out a press release on March 20th promising that there be more guidance released last week, and we didn't receive any guidance last week. So the IRS is still apparently working on what forms and documentation employers will need to gather for that. The small business exemption is still out there for employers with fewer than 50 employees when providing leave would jeopardize the viability of the small business as a going concern. An authorized officer of the business has to certify that one of the 3 conditions exists, either the cost of the leave would exceed the available business revenues. The absence of the employees due to the leave would create substantial risk to the financial health or operational capabilities of the business, or there are not enough workers to perform the labor and services provided by the employees who would otherwise request leave. So those are kind of the three general categories that will justify the small employer exemption. And again, that's going to be an exemption that employers will have to take proactively. There's not going to be an approval process on the front end. So if you take it and you're wrong, the potential for ramifications a month or 2 months down the road still looms out there without further guidance. I hope maybe we'll get some additional guidance on that as well. So let me talk about return to the CARES Act a little bit. The CARES Act made some changes to the Families First Act, but those changes were more explanatory and illustrative. There was no change in the substance of the Family First Act through the CARES Act. So, those details are not really important for us to cover. Everything that we've been told so far last week, this week, and through the publications we've been rolling out have remained the same. The CARES Act just clarified some things really as far as the Family First leave portions. The other financial support in the CARES Act that Kim did not touch on, but I will, is the small business loans. The Act created about $349 billion in funds. I say created in funds. That's a misnomer. The Act will make available $349 billion in emergency paycheck protection program loans and up to $10 million in economic injury disaster loans to small and medium-sized businesses and nonprofits impacted by COVID-19. The Paycheck Protection Program loans are probably the most advantageous. You can borrow 2.5 times your average monthly payroll during the year prior to the date of the loan, and there are some other ways to calculate that for seasonal employers or for newly created employers. That's also capped at $10 million. Obviously, that would be a large employer. Eligibility in the healthcare field depends not on the number of employees, but on the revenues of your practice or of your hospital. The North American Industry Classification System sets up 3 different categories of healthcare employers. There's ambulatory services, which include, standalone practices, clinics, surgery centers, other things like that. There's a significant list of them. Then there's hospitals, and then there's nursing homes and residential care. Each subcategory within those categories has a revenue limit under which they are considered a small business concern for the purposes of these Small Business Administration Paycheck Protection Program loans. So just by way of example, a doctor's office can have up to $8 million in annual revenue and still be eligible for these loans. Hospitals are substantially higher than that. I can send you a link to those if you're interested in that. You can also find out more information about that through the Small Business Administration website. You can use this paycheck protection loan to fund payroll costs, continuation of group health care benefits, mortgage payments, rent, utilities, interest on other debts that were incurred prior to February 15th. So there's kind of broad availability or broad use of the loan to keep your business afloat while you're being impacted by COVID-19. Loan forgiveness is limited. This is one of the great features of this loan. If you maintain your payroll for the course of this emergency period, your loan can be forgiven up to the amount determined by a formula based on any changes in your payroll over the period of time. So the period of time is February 15th, 2019 through June 30th of 2019. And the formula looks at any changes in FTE for your payroll during that period of time to determine what percentage of the loan will be forgiven. The loan forgiveness is also not available for some kinds of expenses. It is available for payroll costs, interest payments on mortgages, rent payments on leased premises, and covered utility payments. So to the extent you use it for one of those four purposes, it can be subject to forgiveness. If you use the money for other purposes, those other purposes are not subject to forgiveness and have to be repaid. If you do have a repayment obligation, a principal obligation, the law goes into the terms of the loan. The interest is capped at 4%. There's no personal guarantee required. There's no shareholder or owner recourse on the part of the SBA, et cetera. So these loans sound like a very good deal. Based on what we know right now, these loans are all guaranteed by the SBA and granted by lending partners. I think that means your local banks in many instances. That's the Paycheck Protection Loan. The Economic Injury Disaster Loan Program is also available. It's up to $2 million loans for small business concerns. Again, that's the same definition I used before. These loan proceeds can be used for sick leave costs, increased material costs due to supply chain interruption, rent or mortgage payment, or paying your other debt that you cannot pay due to revenue loss because of COVID-19. You can get an emergency advance once you apply for these loans, up to $10,000 emergency advance 3 days after you submit your application to the SBA. And the various terms of these loans are substantially relaxed. No personal guarantees for loans under $200,000. No business age requirement. No requirement that you're unable to obtain credit elsewhere, and you get approved for these loans based solely on credit score, without tax returns and without other sort of underwriting data. So another kind of broad overview of the kinds of loans that are available to small business concerns under the CARES Act. Quickly, the last topic I'll touch on, just some unemployment insurance changes under the CARES Act. The Pandemic Unemployment Assistance Program has been expanded to include self-employed individuals, independent contractors, and people who have exhausted their regular unemployment insurance benefits. If you're able to telework or you receive sick leave or paid leave benefits, you're not eligible under the Pandemic Unemployment Assistance Act. The CARES Act extends the maximum number of weeks of unemployment benefits by allowing states to provide an additional 13 weeks of federally funded extended benefits. And it also provides a $600 per week flat amount to each additional recipient of state unemployment benefits for up to 4 months, beginning March 27th and ending July 31st. So without further action by Congress or by, I suppose, regulatory authorities, some employees could earn more money unemployed than if they were gainfully employed, especially those that were working in a minimum wage job. So for low-wage people, this additional amount creates that circumstance. With that, I will turn it back over to Kim to wrap us up. Maybe I'm
Brad, it looks like
supposed to do
Kim
the
dropped
wrap-up.
off.
Oh, I'm sorry. Well, I'll wrap us up then. I want to thank you all again for attending our webinar. We may schedule additional webinars depending on developments. We will certainly address developments as they come out through email updates and materials such as that. And please feel free to email any one of us with questions regarding our content today or things we didn't cover that you wish we would have. We were happy to respond to those questions by email. So thanks again. Please stay healthy out there, and I wish you the best for your practices and your institutions as we go forward. Thanks, and have a great day. Bye-bye.